Hi, and thank you for joining me for another episode of the Cancer Now What vodcast brought to you by Arizona Center for Cancer Care. I'm so happy to be in studio today with two physicians who are going to talk to us about palliative and hospice care for oncology patients. We have Dr. Alaestante, who is the medical director for Agave Hospice and Palliative Care. And we have Dr. Apar Gupta, who is a radiation oncologist with Arizona Center for Cancer Care. Gentlemen, thank you so much for being here today.
It's a pleasure.
Thank you for having us.
Of course. So I would like to start just a little bit, a background on you both. You're both here in the Valley, both physicians, both dealing with lots of different types of cancer patients. I'll start with you, Dr. Gupta. Tell me a little bit about your background and about yourself and why you're in oncology care.
Yeah, of course. So I joined AZCCC in 2022. Before that, I was on the East Coast. I grew up in New Jersey. I went to school at Boston University for undergraduate medical school. I got an MBA there as well. And then I did my residency at Rutgers Cancer Institute of New Jersey. And then after that, I was an attending at Columbia for 2 years where I was in charge of the head and neck multidisciplinary service. But I also treated a wide variety of cancers at their satellites as well.
Cool. That is a very impressive education.
Thank you.
Thank you for being here. Dr. A, tell us a little bit about yourself.
I'm essentially an Arizona native. We talked about this a little bit before, but from a standpoint of managing patient care, I started here as a hospitalist. I'm actually family medicine trained. I started down in Tucson, came back up to Phoenix just to be with my family. But as a hospitalist, we kept on seeing this loss. We'd step away from management and we'd have their patients be discharged, and we never really had a good understanding of what happened to them after the fact. So really, from a perspective of my management, I joined hospice and palliative management so that I could be a part of that, see where we could do better at that management afterwards. Essentially, when you're going inside of a hospital, we see patients who are sick, not doing well, and instead of being able to go to their primary physician or their oncologist or anybody who does their management, a lot of people end up back inside of the hospital. So from a perspective of taking care of people, I wanted to see how we could bridge that gap and see if maybe there was a venue that I could do that in, and I found that in hospice and palliative care.
That's very cool. So you were seeing in your practice as a hospitalist the need for something in between, if
Absolutely.
you will. And you were like, I can do that. I want to help. So that's very cool. I like that a lot. Very good. Well, thanks again to both of you for being here. Dr. A, I'll start with you. How do you explain palliative care to someone who doesn't know much about it?
So the part that's so difficult about that question is a lot of the times you hear hospice and palliative care come together. When you have both those words together, people think that they're the exact same thing, and they really aren't. So hospice, when we talk about hospice care, really talks about end of life. Really, there's not much that else can be done, and from a standpoint of your management, we're looking to give you the best quality of life and really stop the aggressive management and care. Palliative care is everything before then if you have a potential diagnosis that could be terminal. So with cancer specifically in this conversation, really palliative care is just another set of eyes. It's supposed to be availability for another physician like myself, NPs, to be able to provide and manage care at home or wherever facility you're at, but also give and assist in case management, help to bridge that gap so that instead of going to the hospital where this may not need to be hospitalized or situationally, you could have the person be seen by a palliative physician and they could say, hey, instead of going to the hospital, let's make some adjustments to medications, let's communicate with your other physicians and see if maybe we could bridge that gap.
So are you then going to patients' home to do that?
So me personally, no, but our team does,
Okay.
Absolutely. So with Agave specifically, we have an entire team that does go to the homes. They can go to facilities, homes, et cetera, so that we, again, can bridge that gap. From my standpoint, a lot of it is management. If needed, I will go to the patient's homes, but not from a standpoint of my current setting. I don't necessarily go to patients' homes because most of the time I'm actually in the hospital.
Okay, so you're actually working in the hospital and called in as a second set of eyes for someone who's already in the hospital.
Absolutely.
Got it. But there are palliative medicine physicians who will go to a person's home that will help them in the home so they don't have to go to the hospital, because that keeps their costs down too, right? If they aren't hospitalized.
100%. 100%.
Perfect.
Absolutely. So you have physicians that are there that can essentially bridge that gap. Absolutely.
Okay. And then when it comes to hospice, I mean, years ago, it was always brick and mortar, right? It was a hospice facility. Your grandma would be end of life. She would be moved from the hospital to the hospice, and you would say your goodbyes, and that would be that. But hospice doesn't necessarily mean a building that you go to anymore. Is that correct?
100%. So the model that we have in existence is actually you only go to those brick and mortar sites, those locations, when it's really hard to manage care. So if you're having problems with symptoms and they can't be managed at home, we bring them to those facilities. That being said, most people are much more comfortable in their home setting. Most people want to pass away where they're with loved ones, et cetera, et cetera. That was most apparent during COVID, unfortunately. So with COVID happening, a lot of people were being sent to facilities to have that management, but then all of a sudden the doors were closed and people weren't allowed to be in those facilities. And that was very, very hard to see, to watch, the whole 9 yards of that. Our patients didn't like that. And so really the conversation over the past 10 years, it hasn't just been the COVID, but past 10 years, we've really seen that motivation to push people to say, hey, being at home is way more comfortable. We'll provide the nursing staff. We'll bring your physician and your nurse practitioners. We'll bring them to you. How about you be comfortable? We'll get your hospital bed, et cetera, and we'll do that from that standpoint. That way, you're in the most comfortable setting you can be, and we're not causing this disruption of your life, or more importantly, separating you from what's comfortable to you.
Well, and the family, right? They get to be with you. They get to be at home with you. That's huge. I remember,
100%.
and I shared with you, and I've shared with the audience that I lost my sister to cancer, and having her at home with my parents and the care coming into the home was everything, because we got to all be there and, just be together in such a important moment in the journey. So I love that. So palliative care is very different than hospice care in terms of it's not giving up, right?
100%.
Very different.
Yeah,
Okay. Can you just expand on that a little bit?
Absolutely. And again, that conversation between hospice and palliative, you see that grouping together. But with palliative, all of your management continues. There's that conversation about palliative radiation. There's this conversation about palliative chemotherapy. There are all of your other therapies and all of your other management continue to be the same. There's no reason for you to stop that while you're under palliative management, because aggressive management doesn't necessarily mean that we're stopping anything, and palliative management doesn't mean we're stopping anything either. So from a standpoint of what we do from a palliative physician standpoint, we're looking to just have a helping hand in regards to what's happening with your oncologist or your other physicians in completion. So we really saw that from a standpoint of the hospital. What ends up happening is that somebody has a diagnosis, and that diagnosis is truly a cancer diagnosis. It might be terminal, but it's still going to be treated from a palliative perspective. People still want to live. They want to live as long as possible. But you might have a problem that could be managed from a cardiologist perspective. Unfortunately, the cardiologist isn't available, and you get sent to the hospital. But you're not just a cardiology issue. You also have the problem with your cancer and all those other things. Can they handle that? Absolutely. But if you have another physician in the play that knows that you have a cardiologist and you have a palliative physician and you have an oncologist and you have a pulmonologist and all those things, we put all that together so we can say, hey, maybe we can address this a little more aggressively outpatient, preventing your hospitalization, because in the end, nobody really wants to be in the hospital. Right. Everybody would rather be at home, see their doctor from their doctor's office, and then be able to leave and go back to their normal, happy, very comfortable settings.
That makes perfect sense. Thank you. So, Dr. Gupta, help us from a radiation oncologist perspective. How have you seen palliative medicine, hospice aside over there, right? Something totally different, as we now understand. But how does palliative medicine play a role in managing a cancer patient who is in active treatment?
Yeah, no, that's a great question. Palliative care plays a huge role for all of our patients with cancer, whether we're treating them curatively or palliatively. Oftentimes, I have patients that I'm treating very aggressively. Our goal is to completely cure the cancer. And unfortunately, our treatments, whether it's radiation or chemotherapy, have side effects. And that is where, we like to be involved with palliative care as much as possible. And I explain that to my patients that, like you said, patients get a little bit scared when they hear the word palliative care. And we just explain to them that palliative care, you're still getting all of the oncology management that we had planned for you, but palliative care is there to help alleviate some of your symptoms, and that's what palliative means. It means alleviate your symptoms. So whether that's pain that is out of my ability to manage, whether that's the cancer pain or pain from the treatments. It could be, dry mouth. I treat a lot of head and neck cancer, so patients have loss of taste, loss of appetite, difficulty swallowing, and so it takes a whole team of people to really manage these side effects, either from the treatment or from the cancer itself. And so along with me, there's the medical oncologist, there's nutritionists, there's speech therapists, there's palliative care. And so palliative care can oftentimes be very holistic in managing all of a patient's symptoms and put everything together for that patient. So patients, once they understand what palliative care is, some of my patients are hesitant and they're like, oh, I don't think I need to see palliative care. And really it's just a kind of subconscious fear of what they've heard. But then almost all of the time they come back to me and they say that visit was so helpful, and I feel so much better, and they want to continue seeing their palliative care doctor alongside of us. So it's really helpful.
Do you feel like the times are changing a little bit and shifting when it comes to palliative medicine and cancer care? I know, for the 15 years that I've been working with oncologists, I've noticed that the dialogue is much more around bringing palliative care in earlier in the journey and making sure that those resources are available to patients to make it as easy as possible for them to get through treatment. Have you found that people are starting to recognize that it's something a little less scary than it used to be?
Yeah, no, absolutely. I think the earlier that you involve palliative care and the earlier that you help a patient with their symptoms, alleviating those symptoms, the better they're going to feel. So in fact, there's been randomized trials that have shown that palliative care improves survival for these patients. And the earlier that you implement it, the less depression the patients have, the better quality of life, the better functional status. So I think that there's a growing movement in the oncology world to involve palliative care earlier and earlier. And Dr. A could probably speak to this, but I think there's a huge demand for palliative care physicians because we've recognized that this is such a tremendous resource for patients.
Absolutely. One of that conversation specifically on the research that shows that with adding that palliative piece, really people find that there's a lot more satisfaction, and that satisfaction comes from the fact that we're trying to get our patients to be in that same level. With chemotherapeutics, with any type of treatment, really, you're kind of set people back. They get tired, they get fatigued, they get weak. So if we can bolster that therapy by giving them physical therapy, speech therapy, if they're having the dry mouth and all that, occupational therapy, if we can bring those modalities to you ahead of time, as opposed to letting you sink all the way down and then starting from that point, I think from a stepwise function, we see a lot of improvement. We see a lot more satisfaction. Families are much more apt to ask for that information and as well as that guidance early on, as opposed to saying, this is what we're at right now. I didn't even know we could do therapy. We've had plenty of patients say that to us and say, oh, I didn't think that this was allowed at this point. And you're absolutely, we want to do this to you, now. We want you to be able to get that information sooner than later. Absolutely. So thank you for bringing that up.
So it also seems to me that it's almost palliative is preventative medicine almost, right? Like to some extent, if somebody has a little symptom, you stop it from turning into a big symptom or side effect, right? You catch it before it gets out of control. And that is a huge service to a cancer patient, right? Because they talk about the side effects all the time being just so intolerable. So that makes a lot of sense to me, for
Absolutely.
sure.
Yeah, as Dr. A pointed out earlier, palliative care helps patients stay out of the hospital. And why is that? It's because you're catching the symptoms early. You're preventing them from turning into much larger issues that, need hospitalization. So
maybe we should name it something else. You think?
It could use a rebranding, potentially.
It could use a rebranding. I think we should talk to somebody about that. And we might be too far down, though, with the training. Speaking of training, right? And you said that we need more palliative medicine physicians, specifically in oncology. What is the training? Is there a fellowship for palliative medicine? Like, how does one decide that's this, you decide you're going to go into surgery or oncology or radiation oncology or whatever it may be. How do you go down the path of becoming a palliative medicine physician?
Absolutely. So with palliative in general, there is a fellowship that does exist for palliative care. A lot of what has happened in the palliative space is physicians who have been in hospice and are trying to fix that portion where we're not seeing that just kind of fall into the space and become palliative medical directors, which is essentially what I've been. So being in hospice for over, I think it's almost 8 years, from that perspective, I really moved away from that, because the conversation, like I said, from the hospital standpoint, is we see patients go from the hospital and they go to hospice. The patients that don't go to hospice, they go home, and there's that gap. We were seeing that gap was a real space that made it very difficult for patients to see, I don't want to go back to the hospital. I'm tired of going to the hospital. We're so aggressive there. We poke and prod you every single day. We're trying to prevent that. So when the palliative space kind of opened up, and from my perspective, I wanted to learn more about it. It literally is going to classes. There's plenty of conventions in regards to palliative care, because it's such a large space now, and there's plenty of training that's available to people who want to do palliative care, especially physicians that are looking to embolden our patients to be able to take charge of that portion of their lives.
Okay, so it's its own specialty really now.
It is.
Okay.
Absolutely, it's its own specialty.
Yeah.
You definitely can get boarded in it.
You can. Okay.
And even from radiation oncology, in fact, I mean, palliative care is so broad; it encompasses so many things that people have a wide variety of backgrounds and training, and so you can do the palliative care fellowship from a number of different residencies, including radiation oncology. So, a radiation oncologist could do a palliative care fellowship to be, get even more of an expertise in palliative care. But oftentimes, it's internal medicine and family medicine. Those specialties have like a wide variety of types of patients they see. They see lots of symptoms. They know how to manage a lot of different conditions. And so it makes sense for them to move into the palliative space.
That
like
makes sense
Dr.
to me. For sure. Excellent. So, Dr. Gupta, how do you use radiation for palliative medicine? Like how does that work?
Right. So let me just start off by clarifying, whenever there's a new diagnosis of cancer, we as physicians get together as a team and decide with the patient. It's oftentimes a patient-led decision. Is our goal curative or is it palliative? And it's sometimes, it's not always black and white. For, if you have an early stage breast cancer, of course it's going to be curative. And then if you have widely metastatic disease, then usually that's palliative. But there's especially now with all of the different treatments that we have, there is a gray zone, and it depends on the patient's functional status, what their goals are, what their code status is. There's a lot of different things that go into that decision. So we will get together as a multidisciplinary team and decide with the patient, do we want to shoot for a cure or do we want to palliate? And then if the decision is made that this is palliative in nature, then we go down a different set. We're not gonna expose the patient to very aggressive treatments where the side effects may, outweigh the benefit. So we want, there's always a balance of side effects versus benefit. So for palliative radiation, we try and keep things simple so that we can alleviate the patient's, usually it's pain, but it can be different things. It could be spinal cord compression. It could be brain metastasis that we don't want to grow out of proportion and cause neurological damage. It could be bone fracture. So there's a number of different things where the patient is actually feeling, symptoms from their disease. And so we'll treat with a lighter dose of radiation that can help alleviate those symptoms without exposing them to all of the side effects that could come with much larger doses of radiation.
I see. That makes sense. I'm a little confused about one thing, though, if you can help me understand. So palliative versus curative when it comes to radiation, right?
Right.
But outside of the radiation space, it's not a versus, right? That's where the gray area comes in. Is that correct, right?
No.
So because he's saying that you can get palliative care and still be cured.
Right. Okay. So that
You see what I'm
I
saying?
can see why that could be a little bit confusing. So from a cancer perspective, as a team, we at the very beginning, at the time of diagnosis, decide, is this curative or is this palliative? That's in terms of the oncologic treatments, right? How aggressive are we going to be in our treatments? So that I could see where the confusion is, because we could be treating a patient curatively, but we will still involve palliative care, and that's where the terminology is confusing. So palliative care will help with the symptoms even though we're treating aggressively in a curative mindset. But when we're doing palliative radiation, then we're not treating for a cure, we're using radiation as a palliative tool.
Thank you so much for explaining that way, because I already knew the answer, but I know that people are confused about that. And I think that that's really part of some of this rebranding need that we talk about, right? And the confusion is because in your world, it is very black and white, but in your world, it is not very black and white. So Thank you for explaining that.
Yeah, no, absolutely. That's a great question.
So can we talk a little bit about code status? Okay. I don't know. You can tell me which one of you wants to take this one first, but DNR, DNI, full code, how do you know what's going on and what you're supposed to do?
So I'll take
Yeah,
this to start.
Okay.
We have these conversations all the time. So this is part of the advanced care conversation that you have with your patients. And DNR, DNI, full code, all of those are, they have their own separate conversation. But do not resuscitate has to do with whether your heart stops. And, if your heart stops, do you want us to do compressions? Do you want us to give you medications to try to start your heart again? Do you want us to, shock you? All those are the do not resuscitate conversation. Do not intubate is very specifically do not intubate. So putting that tube down your throat to breathe for you to help you in that regard, that is that piece. When you combine the two, the do not resuscitate and do not intubate, it means that if your heart stops, we're not going to do anything from a perspective of medical management to try to make you breathe or try to get your heart started again. That would be the end of that conversation. Full code means that we're doing everything. And by default, all of us are full code, right? If there's no conversation, if we haven't had an advanced care conversation with you, we're going to tell you that you're full code until you tell us not to do that anymore. A lot of these pieces can be put together. There's a selective list of the things that you'll tell us to do. If you want us to be a limited code, you can say, I want you to do chest compressions, but I don't want medications. I do want to get shocked, but I don't want you to do chest compressions. All of those things can be part of that list and conversation. So there's a lot of options in regards to what that is. For this conversation, the do not resuscitate, do not intubate, the first one is do not resuscitate, do not do compressions, do not try to get my heart started again. Do not intubate is just do not put the tube down your throat. Now, that's really that conversation piece, and there's more to that question.
A lot more.
Right. Yeah.
But when do you have that conversation with your patients? Is it as soon as they're diagnosed? Is it when they've been, in the hospital? Like, how do you know when it's time to have that conversation?
So this is a hard topic to broach on any patient anywhere, but
Yeah.
technically speaking, anytime you go into the hospital, a doctor should be asking you that question. Your primary physician should have an understanding of what your thought process is, right? This is supposed to be a longitudinal conversation, so a conversation that happens from a young age. So you can say that as a 35-year-old, I don't want to do X, Y, and Z. As a 38-year-old, I don't want to do X, Y, and Z. All of a sudden you get to, I'm at 65 and really I don't think I want X, Y, and Z. You want to be able to have that conversation. So the DNR, DNI conversation should happen at all spectrums of your healthcare, but most importantly, when you go to the hospital, when there's an acute event, or in the case of some sort of cancer therapy or any type of cancer diagnosis, you obviously want to have that at that point. We're not saying that that's the end. We're just saying, I want you to start thinking about this because there's going to be a time, I don't know when, but there's going to be a time where this is going to be much more of a serious conversation. And we want to do what you want us to do. We don't want to put anything on you. We don't want to do anything forcibly to you. We want you to make those decisions before it happens.
And we're not saying we're going to have to do anything. We just want to be prepared just in case we have to,
Right.
Which is so important to people. I mean, I'd want my doctors to know what my wishes would be for sure.
Absolutely.
Anything to add there? Or?
No, I totally agree. I think ideally this conversation is had a long time in advance of ever needing it with the people that you trust most, your family, your friends, and your physician. So it's harder to get a really accurate depiction of what a patient wants when they're already really sick and they're coming in the hospital and they're already suffered some trauma and you can't even ask the questions, versus if they have something on file that they've had discussions with people they know, it makes the process a lot smoother. So as oncologists, it's not something that we ask the first time we meet the patient because that would be very jarring. But once you get to know the patient, then you can also get to know their wishes, and then you can clarify some of those. And then oftentimes in coordination with palliative care colleagues, we kind of will get together and know what the patient's wishes are from one conversation or another.
That makes perfect sense. Thank you.
Yeah.
So my last question really is about who pays for all this, right? So this is a lot of specialists for one patient. We're adding, it's not new, but we're adding another physician to the care continuum. Does insurance cover it? Is it covered, or is it something patients have to come out of pocket for? Like, how does that work?
So from a palliative, I mean, this is probably in my
Yeah.
for you guys, it's all.
They're
on the
the
insurance.
oncologists are definitely covered.
Yeah,
I know that.
From a palliative perspective, palliative is covered by Medicare. CMS has cut that and carved that out for the majority. The majority of insurance companies have all agreed to continue managing and paying for palliative care from insurance, but it's not necessarily specific to each one of those. It's one of those we find out after the case, but it really is a conversation within Agave to say, what does that look like for us? Are we going to be sitting there charging our patients with an astronomical number of bills, X, Y, and Z? It's really interesting because a lot of oncologic patients are very young. They're not patients that have gotten to the point where they have CMS or Medicare. So that conversation has made it really hard on them. But from our perspective, I mean, we are making sure that we take care and we cover as much as we possibly can. And then our conversation from a financial perspective is to just make sure that people are aware of what's happening. I've never had that conversation. I don't get it, to be frank, from a palliative perspective and a medical director perspective, we don't get paid per encounter in that way. So it's not one of those things like, you're my palliative patient, you're on my palliative patient, you're on a census of patients, and I just want to take care of you. But from an insurance perspective, that would be a conversation to have with Agave and just make sure, hey, I don't want to be tacked on a whole bunch of bills, X, Y, and Z. Can you just make sure that my insurance is being taken care of in this regard?
Well, and that's true in oncology as well, right?
Right.
You have to make sure that your provider takes your insurance.
Right.
Not every provider takes every insurance plan. So it's really the same. So that makes a lot of sense to me.
And I think they're also expanding indications, as insurance companies realize that this is what patients really need. It's a proven benefit to patients. And these randomized trials have actually shown that palliative care reduced overall cost of care because the patients are avoiding hospitalizations
Absolutely.
and much more expensive therapies. The insurance companies actually stand to benefit from involving palliative care early.
That makes sense.
So, and then especially when patients have cancer, that's always an indication for palliative care to get involved. So insurance companies will also look at the indication, and I think it's more uncommon for a patient with cancer to be denied some kind of palliative care involvement than another diagnosis. So, but really they've really expanded over the years as it's become more and more publicized.
So you're not doing a ton of peer-to-peers for palliative care?
No, not at all.
Okay, got it. Perfect. Well, is there anything else that either of you wanted to share about palliative care and hospice as it pertains to oncology patients before we wrap up?
No, I mean, I think this has been great. It's a great resource for patients. I try to educate my patients that palliative care is so important, and that they have a lot to gain from it. So I'm hoping that, anyone who's watching this can kind of take that as their takeaway.
Excellent.
And I'll jump right on that. I think that the real conversation for our patients to understand from a palliative perspective is that we're not taking anything away. Our
Right.
objective is actually to add to your management and your care so that you have the best outcome for as long as possible, prevent your hospitalizations, and decrease that rigmarole, that question that I don't know if my patient, my doctor knows about what's going on with me. We just have a set of hands to help kind of carry what's happening in the medical system. It is not an easy system to navigate, and so we just want to be a part of that to help with our patients to make sure that they have the best and the most of their care as possible.
Yeah.
Excellent. Thank you both so much for being here. Really appreciate it.
Thanks
And
so
thank
much.
you all
Thank
for
you.
watching. If you would like more information on Dr. Alaestante, Dr. A, who is the medical director of Agave Hospice and Palliative Care, you can find him at agavehealthcare.com. If you would like more information on Dr. Gupta, who is Radiation Oncology with Arizona Center for Cancer Care, you can find him at arizonaccc.com. Thanks so much, and we'll see you next time.